For joining today. This is a CME presentation that's been put together by peer review. And really we wanted in a two-part series to cover preparing your practice for the new era of amyloid targeting therapies. Um, just to go over a few notes here, we want to thank peer review and Eli Lilly for providing an educational grant for this activity, but it is really intended to be free from all bias. You should have received a link to get the CE credit for this, and we have a post-test and evaluation. And then, we really want this to be as interactive as possible. This ECHO program is really unique. Many of you may not have been a part of this in the past, but really it is all teach, all learn. So in the beginning of our presentation here, we're going to have some educational PowerPoint presentation in sort of the traditional way. And then we really want to try to provoke some discussion. We want you to bring forward interesting patients that you've seen where you've really pondered the idea of them being on therapy or not, and pose those questions, and we'll let the audience and the experts here try to help with working through those cases. And we also have some sample cases we're going to work on as well. But ultimately, we would love for all of you to be interactive in this and asking questions so that we can give the best information.
Battery 100%. Connected to James's iPhone 2.
There is accreditation information. So just as a housekeeping issue, try to keep your microphones on mute until we get to the questions part of the session. But also we have accreditation information here. We have also some information on mock and nursing-based accreditations, and then physician assistance-based accreditation as well. We have disclosures from myself and our other speaker today, Dr. Rabinovici. And as I said below, or said before, we're going to do and try to present this in the most unbiased way possible. If there is anything where we discuss off-label use of medications or, indications that are not specifically described in prescribing guidelines, we will let you know that. So this is part one of a two-part series. The second presentation will be Thursday, January 9th. Dr. Rabinovici, who's giving our talk today, is one of the lead authors of the lecanemab appropriate use recommendations, one of the lead authors of the donanemab appropriate use recommendations, which will be published in the first quarter of 2025. So his presentation today and his availability to all of us during this for questions and so forth is really valuable. So our goals for today's CME presentation is really to enhance your understanding of the amyloid targeting therapies, the risks and benefits of those, helping you try to identify the most appropriate patients who have early symptomatic Alzheimer's disease and who these treatments might be most effective in and who might have higher risk with those treatments. And then really trying to have a discussion with you about how you approach patients and in a shared decision-making model when discussing who really is appropriate. Even though you might meet the criteria, does that mean that amyloid targeting therapies are right for you? With that, I'm going to turn it over to Dr. Rabinovici for our didactic for this ECHO today.
Thanks so much, Dr. Brosh. Really a pleasure to be here to talk about this exciting new era of disease-modifying therapies in Alzheimer's disease. So the first part of the presentation is really going to talk about the mechanism of action of these drugs and the evidence for efficacy in patients who have early symptomatic Alzheimer's disease. And so this cartoon depicts the A-beta aggregation cascade. A-beta is derived from the amyloid precursor protein, or APP, which is a transmembrane protein that's expressed in neurons, as you see on the top left of the figure. And sequential cleavage of APP by beta and gamma secretase generates a polypeptide fragment of various length, but particularly the 42 amino acid version of this polypeptide is a sticky protein. So one A beta sticks to another. They form initially soluble aggregates called oligomers, and eventually protofibrils, fibrils, and the amyloid beta plaques that we can see under the microscope. The way the amyloid targeting monoclonal antibodies work is they are delivered intravenously or soon we think subcutaneously. A small percent of them get into the brain and they mark different elements of this A beta aggregation cascade. And this really signals to the immune system to go ahead and target these pathologic proteins. And so this activates macrophages, which ultimately leads to phagocytosis and removal of plaques. Now, even though we tend to lump this class of drugs together, the antibodies really target different aspects of the A beta aggregation cascade. So the two antibodies that we're going to talk about today, which have traditional FDA approval, are lecanemab, which targets protofibrils, and donanemab, which targets mature plaques. Interestingly, drugs that target the more soluble forms of A beta, like solanezumab, that targeted A beta monomers, actually haven't shown very robust clearing of amyloid plaques on PET, nor have they shown clinical benefit. So there does seem to be a relation where the antibodies that target more of the fibrillar or aggregated forms are the ones that are clearing plaques, and really the clearance of plaques, as we'll see, is associated with some clinical benefit. These graphs show changes in amyloid PET in the pivotal phase 3 studies. These were placebo-controlled, double-blinded, randomized clinical trials that assessed the efficacy of lecanemab on the left and donanemab on the right. The trials were called Clarity AD and Trailblazer, respectively. And these clinical trials recruited people who had early symptomatic Alzheimer's disease. So they had either mild cognitive impairment or mild dementia. As we'll see, they were positive on an amyloid beta biomarker, and there were certain criteria for inclusion and exclusion. What you see in these graphs, starting with the left, is changes in amyloid PET on the y-axis using a scale called the Centiloid scale, which is a way of measuring amyloid PET aggregation. You can see that the placebo group is kind of stable to slightly increasing over time, whereas in the lecanemab group, over 18 months, you can see a reduction in amyloid PET signal. Overall, people in the trial started with an average of about 75 centiloids, and the average reduction was close to 60 centiloids. The threshold for a positive PET scan is around 25. And so you can see ultimately that 68% of the participants had actually completely cleared plaques on PET at the end of the trial at 18 months. On the right, you see a similar graph for the donanemab Trailblazer ALZ 2 phase 3 study. And you can see on the top the placebo groups, and on the bottom the donanemab groups, and you can see again a rapid reduction of plaques on PET, an average of over 80 centiloid reduction, ultimately with just about 3/4 of the participants in this trial being amyloid PET negative at 76 weeks. And very importantly, this reduction in amyloid PET signal was associated with a slowing of clinical decline. This can be measured with different clinical scales. The one we see here is called the Clinical Dementia Rating Sum of Boxes, or CDR-SB for short. This was the primary outcome in the Clarity lecanemab trial and a key secondary outcome in the Trailblazer ALZ 2 study. We're just showing the same scale for the two trials so that you can sort of compare them side by side. And this is a very clinically meaningful scale. So it's a composite scale that measures both cognition and daily function. And going down on the y-axis indicates disease progression or worsening cognition and function. What you see on the right is that in the Clarity study, the placebo group declined about 27% more than the lecanemab group at 18 months. And then very similarly on the right graph, you can see 29% slowing in this on this scale in the donanemab group compared to placebo. So this represents slowing of clinical decline using a very meaningful clinical scale. And really, this evidence of clinical efficacy is what led to traditional FDA approval of the drugs lecanemab in mid-2023 and donanemab just earlier this past summer. Now, the primary adverse effect that we're concerned about with these drugs are amyloid-related imaging abnormalities, or ARIA. These represent fluid shifts, either edema or hemorrhage, that can occur spontaneously, but also occur with treatment of this class of antibodies. And this is such an important thing for us prescribers to be aware of, that you're going to get a whole session about safety and ARIA from Dr. Salloway after the new year. ARIA can occur in two flavors. And so just looking at these axial MRI images, on the left, what you see is ARIA-E, which presents with edema or sulcal effusions. This represents, we think, inflammation and exudation of fluid as a result of treatment. You can see that on the flare sequence with the white matter hyperintensities, and also you can see some hyperintense signal in the gray matter. This would be graded moderate ARIA-E. I think Dr. Salloway will go over the grading system. The other flavor of ARIA is hemorrhagic. This typically presents with microbleeds, as you can see on this probably gradient echo sequence on the right. All those little tiny dark dots are microhemorrhages in the setting of treatment. There can also be siderosis or superficial deposition of hemorrhage on the brain surface, and rarely, but significantly, there can also be macrohemorrhages, so intracranial hemorrhages, which, as we know, can be are associated with quite high morbidity and mortality. Now, these images look scary. The patients usually look good, and so about 3/4 of the time, ARIA is entirely asymptomatic and is simply detected because we do safety MRIs as we treat people to try to detect this early and modify our therapeutic approach accordingly. About 1/4 of the time, there can be symptoms. These are usually mild and nonspecific, headache, dizziness, a little more confusion, but rarely there can be serious symptoms associated with ARIA, including stroke-like episodes, seizures, even status epilepticus, malignant hypertension, and there have been deaths associated with severe ARIA. And so those are very rare, but obviously very serious. And this is really the main reason why we have some guardrails around who we treat with these drugs in terms of safety and trying to minimize the risk of ARIA, and especially the risk of symptomatic or severe ARIA. This table shows you the rates of ARIA-H and ARIA-E in the two phase 3 trials, lecanemab and donanemab. And it shows you these rates by ApoE genotype. So as you all know, ApoE4 is the most common genetic risk factor for sporadic Alzheimer's disease. And it turns out it is really a very significant risk factor for ARIA, both ARIA-H and ARIA-E. So you can see that, for example, just looking at the lecanemab column, the rate of ARIA-E on the bottom is 5% in E4 non-carriers, about 11% in E4 heterozygotes, but over 30% in E4 homozygotes. And similarly with donanemab, those rates are 15.7% in non-carriers, 22.8% in heterozygotes, but 40.6% in homozygotes. So there really is a strong effect of ApoE, particularly for homozygotes, in the risk of ARIA. The other adverse effect that we should all be aware of are infusion-related reactions. These are more common with lecanemab. They occurred in 26% of patients in the phase 3 trial. More rare with donanemab, about 9% of patients in the phase 3 trial. So how do we identify the appropriate patients for treatment? And what I mean by appropriate patients are patients who we think would derive a clinical benefit based on their clinical disease stage, but also patients in whom the treatment will be safe. And this is really based on exclusion criteria, particularly pertaining to their risk of ARIA. So this is kind of a flow of the clinical workup that you would do when you're considering a patient for treatment. The first step, of course, is your clinical diagnosis. So a diagnosis of MCI or mild dementia. that clinically you believe is due to Alzheimer's disease based on your overall assessment, cognitive testing, the disease phenotype. Of course, as part of your medical and neurological history, you're ruling out non-Alzheimer's etiologies of cognitive impairment, either systemic, medication-related, sleep-related, or alternative neurodegenerative diseases like Lewy body disease, vascular dementia, et cetera, that can also lead to cognitive impairment. And MRI can be very helpful in identifying patterns of atrophy or looking at vascular injury that can help you with your diagnosis. If you're thinking of treating a patient, you really need biomarker evidence of amyloid pathology with something that's called a core1 biomarker in the new criteria for Alzheimer's diagnosis and staging proposed by the Alzheimer's Association. We'll go over which biomarkers would qualify. The MRI then is really important also for looking for exclusionary factors, in particular, evidence of cerebral amyloid angiopathy or CAA, vascular amyloid deposits that present with microbleeds or siderosis. What we think is that ARIA is really an inflammatory version of CAA. And so if patients have clear evidence of CAA, you probably don't want to treat them because they would be at high risk of having not only having ARIA, but probably having severe ARIA. And these patients were excluded on that basis from the clinical trials, which is another reason to exclude them in clinical practice. We don't actually know the overall safety profile for patients who have CAA at baseline. ApoE genotyping is now strongly recommended because really, if you're going to have an informed discussion about risks of treatment, you need to know the patient's ApoE genotype in order to be able to counsel them appropriately about their risk of ARIA. And then the sixth step is education that happens with the patient and the care partner about benefits and risks after you've done the complete clinical profiling and engaging in shared decision-making to determine if this drug is consistent with the patient's goals and values. And if so, then you initiate the treatment. There are different ways to stage clinical disease. This is, again, from the new Alzheimer's Association diagnosis and staging criteria published earlier this year by Cliff Jack and colleagues. I think a lot of you are familiar with terms like mild cognitive impairment, mild, moderate, or severe dementia. In the current formulation, stage 1 refers to patients who are on the Alzheimer's continuum based on their biomarkers but are asymptomatic or have preclinical disease. Stage 2 is similar to what we've called subjective cognitive decline. So the patient is noticing some changes or others around them, but they're still scoring normally on cognitive tests. The amyloid targeting therapies are approved for stage 3 and stage 4. So stage 3 is mild cognitive impairment, where patients have a decline in their cognition. It's confirmed on objective cognitive testing, but they're still largely independent with day-to-day function. And then in stage 4, or mild dementia, patients require some assistance with more complex activities of daily living, like finances, driving, planning, scheduling, but are independent with basic ADLs. And so really the clinical trials and the patients in whom these drugs are indicated are stage 3 and stage 4 patients. This is a table from the new criteria talking about the biomarkers that can be used to confirm amyloid pathology. The two that are currently recommended in the appropriate use recommendations are amyloid PET scans that are read by radiologists or nuclear medicine physicians as showing either elevated or non-elevated amyloid, or CSF-based biomarkers. And the best readouts from CSF are ratios, actually. So not individual measurements, but ratios of A beta 42 to 40, phosphorylated tau to A beta 42, or total tau to A beta 42. And there are now a number of CSF assays that have FDA approval, with the primary readout being these ratios. This is more reliable than just measuring, say, the amyloid beta 42 measurement. Blood-based biomarkers and plasma are very close. There's still a lot of variability in the performance of some of these biomarkers that are commercially available, and none are yet FDA approved, but I expect that will change literally in the next few months. And the ones that are recommended in the criteria paper for diagnosis as standalone biomarkers are is the highest performing blood-based biomarker, which is phosphorylated tau at position 217. And so at the moment, we're not using these to qualify patients for treatment, but as soon as there are FDA-approved blood tests that meet certain performance criteria, I think actually blood-based biomarkers will in and of themselves be sufficient, the high-performing ones at least, for determining eligibility for therapies. Here you can see inclusion and exclusion as provided in the FDA prescribing information for the two drugs. There are some subtle differences in the labels, but they're pretty similar overall. So you want a clinical diagnosis of MCI or mild dementia due to Alzheimer's, confirmed amyloid positivity, as we discussed, based on PET or CSF, and an MMSE that is approximately in the 20 to 30 range. There's some subtle differences in the inclusion in the trial, but this is just about the range in clinical practice for patients who are treatment eligible, and that would translate to a MoCA usually greater than or equal to 18. And then patients are excluded really if they can't undergo MRIs. If they have metal implants and you can't monitor them for ARIA, you can't treat them, unfortunately. If they have evidence on their baseline pre-treatment MRI of significant CAA, as indicated by greater than 4 microhemorrhages, on the label, it says greater than one area of superficial siderosis. The appropriate use recommendations, with Dr. Broach referred to, are a little more conservative than the label. They recommend excluding patients who have baseline siderosis, and we can talk more about the rationale for that during our discussion. I'm sure Dr. Salloway will also bring this up in his talk next month. The other thing you're looking for is really evidence on the MRI that cognitive impairment is largely driven by vascular dementia or vascular cognitive impairment as opposed to Alzheimer's. So that would include severe white matter changes, multiple lacunar infarcts, large cortical infarcts, et cetera, that would indicate again that the cognitive decline may have a strong vascular component, and for that reason, treating the amyloid may not provide as much benefit. Patients who have unstable medical and psychiatric conditions, there's some recent data that suggests that hypertension is actually a risk factor, a modifiable risk factor for ARIA. So that's something to watch out for. And then the labels say that patients on anticoagulants should be treated with caution. The appropriate use recommendations, again, a little more conservative, currently exclude patients who are on chronic anticoagulation. And that is really because of the concern about ARIA-H macrohemorrhages. And we know that the morbidity and mortality of ICH in patients who are on anticoagulation is really very high. And so even if these events are rare, they can have very significant consequences. And we can debate this, but again, I'd say at least extreme caution, if not exclusion, of patients who are on chronic anticoagulation. And then ApoE genotype testing, again, is recommended in order to have a fully informed discussion about risks and benefits. This is one pathway looking at sort of the sequence of how you might work up a patient in your clinic. So of course, you start with your clinical assessment, including cognitive testing and an MRI. Patients may be deemed inappropriate based on this initial workup. If they're still candidates for therapy, you might want to do the biomarker testing with PET or CSF. If the biomarkers are positive, at that stage, you might do the ApoE testing and then have the fully informed discussion and shared decision-making about treatment. Why do we recommend testing people for ApoE? Well, ApoE4, as I showed you, is associated with a higher incidence of ARIA, earlier ARIA, a higher rate of recurrent ARIA, and more severe ARIA. So really, it is a very strong risk factor. Doesn't mean that patients can't be treated or shouldn't be treated, but as the patient should be fully informed, the family, and of course the clinician, about the potential risks. And so this is really why this is a change in our clinical practice. I think for a long time, ApoE testing wasn't recommended as part of a clinical workup. We certainly didn't do much of it at UCSF, but now every patient who is being considered for treatment, we go ahead and do the ApoE genotyping. An important topic that we need to consider is related to racial and ethnic disparities associated with Alzheimer's, dementia, and also clinical trial inclusion. And so there are multiple studies that suggest that, in particular, older Black, Latino, and Hispanic Americans have a higher risk than non-Hispanic whites for developing dementia. And even though the prevalence is higher, there are a number of studies that show that individuals from these minoritized groups are diagnosed at a later stage and have a less comprehensive evaluation early on. And so these are important goals for us to address in terms of disparities and access to care, diagnosis. And as it pertains to the clinical trials, the inclusion of these groups, as well as other traditionally underrepresented groups, was really quite poor in the phase 3 studies. And that, I think, raises some questions about generalizability and is an important consideration when you're counseling your patients who may come from one of these groups, just to be really honest and transparent and say that the trials fail to be inclusive of these groups. And this is something that people should just be made aware of. Okay, so how do we then engage in shared decision making to make good choices about treatment? It's really important to identify what are the patient's goals, their values, and their preferences in terms of whether these therapies are right for them. And very, very important for the patient to the degree possible and the care partner to be actively engaged in the decision-making process. And then also establishing realistic expectations about the benefits of these treatments. As I showed you, they're associated with a slowing of clinical decline. They don't improve cognition. They don't stop the decline. And so it's really important just to have realistic expectations for the patients as they engage in this journey with you. So how do you talk about expected benefit of treatment? As I said, I'm really realistic with my patients. I say this isn't a cure. It's not going to make your memory better, not going to stop the decline. But our hope is that it will slow the decline and that might be meaningful in terms of keeping patients as long as possible in this early clinical stage where for many patients, their quality of life is still really good. Really important to inform patients about ARIA and the symptoms to watch out for. We do, and you'll hear a lot more about this from Dr. Salloway, but we have some routine MRIs that are done as checkpoints as you're treating patients before dosing the infusions to make sure there is an asymptomatic ARIA. But obviously, if there's ever a clinical suspicion of ARIA based on the patient developing symptoms, that is a cause for an urgent MRI to evaluate that and talking about the risk of ARIA as it pertains to the patient's overall profile in terms of their ApoE genotype, their baseline MRI findings, other medical conditions, other medications that they're on. These treatments are really intense. They involve a huge time commitment, form the patient and family in terms of frequent infusions. Lecanemab currently is every 2 weeks. Donanemab is every 4 weeks. So these are really frequent infusions. And then there's all the additional testing, right? The PET scan or CSF testing, all the MRIs to monitor for ARIA. So important for patients to realize what they're getting into and to make sure that the benefits of the treatment are worth this additional burden. Cost is really important, determining whether there will be out-of-pocket costs and what the extent of that will be, what is the coverage for the patient. I will say that for patients who have traditional Medicare, these drugs are covered as part of a national coverage decision, lecanemab and donanemab both. Patients do have to be entered into a registry the goal of the registry is really to determine long-term safety and efficacy of these drugs in the real world. There are a number of options for this, but as long as you can enroll a patient in a registry, the treatment should be covered. And of course, the safety and efficacy have been determined in the clinical trial populations. And we didn't go into the detailed inclusion-exclusion criteria, but in general, we have less data about benefit in patients who are much younger or much older than the patients in the trials. The average age in the trial was about 72. We really don't know much beyond the year and a half or so that was the duration of the phase 3 trials. We can talk a little bit about stopping, or maybe that will be the subject of the next ECHO meeting. But how long do we treat patients? What are some reasons to stop? How do those differ between the two drugs? And there's always the potential for participating in a clinical trial of a different drug, for example, a drug that targets the tau tangles. And so that may be a consideration for patients as well. This is a really nice sort of handout to give patients about ARIA. You can see that it defines ARIA. It talks about the ApoE risk, and it shows really nicely some of the potential symptoms of ARIA so that patients and families can recognize these and get an evaluation if any of these symptoms emerge. And this is something that's really important. This is a card that patients can carry in their wallet that describes that they're on an amyloid targeting therapy. This is really important because if patients present to the emergency room with an acute or subacute onset of a focal neurological syndrome, it looks a lot like stroke, but it may actually be ARIA. And the workup would be very different. ARIA is not typically picked up on a CT, and so really requires an MRI for diagnosis. And really critically, patients who have ARIA should not be given IV thrombolytics like TPA. There have been a number of deaths associated with severe ARIA-EH when patients presented with ARIA were treated for strokes with TPA, and that led to really catastrophic consequences. And so this is something to discuss with the emergency room services, vascular neurology services, if you have those in your community, and again, to talk with patients and to have them carry this wallet so that if they do come in for urgent or emergency care, the providers are aware of the drugs they're on. There are also a number of patient assistance programs available for both approved drugs, can help with locating infusion centers, sorting out the insurance coverage and the financial burden, et cetera. So these are good to know about and can be very helpful for your patients. And so I don't know if we're going to stop for Q&A or should we move on to the case discussions with Dr. Brosh?
Yeah, no, this is great. Thank you, Dr. Rabinovici. We've had a couple of great questions in the chat if you haven't had a chance to look through those. If you have any questions at this point for Dr. Rabinovici and his presentation and you'd like to just go ahead and unmute and begin speaking, we would love to hear that. Otherwise, let me just talk about the two questions that were in the chat. First of all, the first question was about PET scan reimbursement. And at least in our state, the MAC that controls reimbursement in our state for Medicare, we really weren't seeing great reimbursement for PET scans until about summertime 2024. And since then, we've been able to pretty consistently get amyloid PET scans for our patients. There may be a co-insurance payment that patients have to make along with that PET scan, and that may depend on if they have supplemental coverage and so forth. The other question is about how long the infusions take. So, the infusions, the first few at least, we have a monitoring period for infusion reactions to look for hypersensitivity. And the actual infusion takes less than an hour or so, but we monitor for a few hours afterwards with those first few infusions. But eventually a person can get in and out of an infusion chair within 60 to 90 minutes and beyond their way. Looks like we have another question. Can we get a copy of patient handouts, ARIA handout and patient card? Absolutely. We will make this available after the presentation today. We definitely hand out those cards to individuals and inform them about those things. Looks like we have another question about regarding risk benefit to starting therapy. Do you include a talk about anticoagulation as well? Do you give them any emergency card for IV thrombolytics? So as Dr. Rabinovici said and showed, we do give all of our participants a card, and we'll make that available today so that they're aware and educate them on how they cannot receive thrombolytics. We tell them and we reinforce the idea that you should still go to an emergency department because mechanical thrombectomy is still possible. And certainly we would want them to receive that sort of therapy if they were eligible to receive it, but we cannot give TNK or TPA to these individuals without risking cerebral hemorrhage. And we do talk about the fact that if they do develop atrial fibrillation at some point and need to go on to anticoagulation, this therapy may need to be stopped. Looks like we have another question. Dr. Hetrick, the Trailblazer study included 98 patients on anticoagulation without clear adverse effect in these patients, though my understanding is it wasn't quite powered for this. This is a great question. There are still individuals on anticoagulation in the clinical trials. I think we're gathering evidence for that. Dr. Rabinovici, did you have a comment? Can you make any comments on the experience thus far with the patients on anticoagulation?
Yeah, it's a really good question. So I will say, first of all, there's really a paucity of data. Most of the trials with this class did not allow patients on anticoagulation. Some of the more recent trials, including the Trailblazer-ALZ 2, did allow anticoagulation, but it was at the discretion of the site PI. And so not only are there not a large number of patients, but also these are patients that were probably selected by the site PIs to be lower risk overall based on their overall profile. And there's conflicting data. So actually in Clarity AD, the numbers were small, but there was a higher risk of intracranial hemorrhage in people who were on anticoagulation compared to those who weren't. That wasn't seen in Trailblazer. But again, the concern is that if you have an ICH on anticoagulation, the morbidity and mortality are really, really high. And so it's out of an abundance of caution, I would say, that at least at our center, we are not treating patients who are on anticoagulation. There will be more of this tested in trials and through real world registries like I didn't mention this, but the Alzheimer's Association has developed a registry called ALZNet that's monitoring patients every 6 months initially for 2 years and then every year, and which medications they're on, what are their ARIA outcomes. So I think we're going to gather a lot more data about patients on anticoagulation. We'll be able to refine our criteria. The other point is that there's a huge learning curve for these class of drugs, not only for us as prescribers, but also for our colleagues in radiology, neuroradiology, in detecting ARIA. And you have to remember that in the clinical trials, all the safety MRIs were read by central readers that were highly experienced. In the real world, it's unlikely that most radiologists will have seen a lot of ARIA. And the concern is that if early ARIA, which can be really subtle and tough to see on MRI and tough to distinguish from sort of chronic microvascular changes, if that's missed early on and patients are dosed through that inappropriately, then that can lead to severe ARIA and ARIA-H. And so again, another reason to be more cautious during this rollout phase of this new class of therapy. And as we gain experience as prescribers, as our radiology colleagues gain experience in reading these MRIs, the hope is that we'll be able to loosen some of these criteria a bit.
Thank you, Gil, for that. That's great. And this raises another point. The criteria say that we can use 1.5 Tesla or 3 Tesla scans, and the difference between those two is that the 3 Tesla scans are much more sensitive for hemosiderin deposition. So we're going to see more ARIA-H on a 3 Tesla scan than we will on a 1.5 Tesla scan. And it's simply put, there isn't access to 3 Tesla scans everywhere. We try and have as many of our patients scanned on 3T as we can, but we know that that's just not an option for everyone. So keep that in mind. And some of the early work that people should do is working with their radiology departments, working to develop a template so that when they report these safety MRIs, you get the information that you need to determine if they should go on to the next dose. So we found that to be very important. And if you hear of one of your patients having developed PRESS, that's likely ARIA-E if they're on treatment, and an inexperienced radiologist will often read it that way. All right, well, I don't see any other questions in the chat. So what I'll do is I'll move forward here with just a couple of provocative case presentations. But feel free to send more questions in that chat or just start talking. We're happy to hear from you. So in this brief case presentation, we have a 66-year-old Black woman with MCI. And again, this is really important that we added that this is an individual who is Black. And we talked about how the studies really did not look at underrepresented groups very well at all. In fact, some of the studies had 0.6% individuals who were Black or of African American heritage. We also know that the rate of Alzheimer's is much higher in Black individuals, and that they also don't have the same amyloid positivity rate. So there's a lot of interesting caveats that we're all still trying to learn about in our underrepresented groups. This person has some mild bifrontal atrophy, mild bilateral hippocampal atrophy, some mild to moderate small vessel ischemic disease, and two lacunar infarctions. So if this person were to get uh, a CSF biomarker test that came back like this, how would we interpret these test results? So we're seeing that this person has some slightly lower A beta 42, but their p-tau 181 level is still within the normal range. Their total tau level is still within the normal range. Does anybody have any comments on what they might do with a set of test results that look like this? Anybody from our sites out there? Throw your ideas in the chat, speak up, come off mute. What do you think? I'm not hearing a whole lot yet. So here, Dr. Ahmad, thank you very much. Consider getting a PET scan in this individual. I agree. I agree. If this is someone, and we specifically in this case didn't really talk about their cognitive assessment, but if this person had a really amnestic looking profile, if let's say on their MOCA that you performed, they scored 0 out of 5, or you decided to move forward with neuropsychological testing given your concerns, and it showed a very amnestic profile concerning for Alzheimer's, then getting another assessment of biomarkers may be a good idea in this person, given we know that their Black heritage may not lead to them always showing amyloid positivity on certain sets of tests. And this is something that we're really trying to learn more about. Otherwise, this person doesn't have exclusionary criteria for receiving one of the newer medications. So I agree. I would probably move forward, depending on how that cognitive profile looked, with an additional biomarker test if available. Does anybody else have a thought on what they might do with this case?
Yeah, I agree. It's really on the threshold. So just to remind everyone, the best interpretation for CSF is the ratio. In this case, the p-tau 181 to A beta 42 ratio. And so in this case, it's right on the border. And so I do think that another biomarker test can really help sort of break the tie. And totally agree, Jared, with your points about what type of MCI is it? If it's a very dysexecutive MCI, and not really an amnestic profile. We know there's significant vascular risk factors and vascular disease on MRI. I might be inclined to think, well, this, maybe they're in early stages of amyloid, but maybe this is really vascular driven in terms of the cognitive impairment. And for that, point of view, maybe the anti-amyloid therapy isn't the best treatment. Maybe it's more about optimizing control of vascular risk factors, for example.
Great points. Yeah, another comment in the chat, you could, along the same lines of what Dr. Rabinovici was saying, you could theoretically offer a cholinesterase inhibitor at this point, work on those vascular risk factors, and then consider rechecking a cognitive assessment or doing another biomarker assessment down the road, depending on your clinical acumen and thoughts on this case. Great points. Great points. All right, we've got another slightly different case. This person, very similar to previous, really just a couple of mild changes, only one lacunar infarction instead of two, same risk factors. This time we have received a plasma-based biomarker assessment. This biomarker assessment was with phosphorylated tau 217, which is, as Dr. Rabinovici said, one of the most accurate plasma-based biomarkers that we have. Now, this one was not a ratio with non-phosphorylated, or it did not include amyloid ratios either, but this blood test standalone is still very accurate. And this put us clearly into the positive range. So how would you interpret this test in this individual, and how would it affect your management? Feel free to unmute and tell us what you think. Throw a comment into the chat. If we go back to what Dr. Rabinovici was saying earlier, the blood-based biomarkers can really give us a push forward. We can perhaps speed a person on their diagnostic pathway to getting closer to an anti-amyloid therapy, but we don't tend to, at this point, just rest here, right? We may want to back that up with some further testing. So, most likely in a case like this, until we have those FDA approvals and perhaps some consensus statements on how we use blood-based biomarkers, this person might be someone you'd want to do another biomarker assessment in as well. This is a person I would probably counsel that they have a very high likelihood of having Alzheimer's disease as a cause for their symptoms, and that we would need to do further testing. And it might also be worth initiating a discussion at this point. Even before you do that test, would you want to receive amyloid lowering therapies? Is that something you're even interested in? And starting to have that discussion before we just say, okay, well, let's get an amyloid PET. We might want to take a step back and think about it for a second with the family and everybody involved. Have people had conversations like that? Is that something that you do in your clinics?
We do, Jared, just to get the discussion started. So we use plasma p-tau217 in our practice. We use it mostly for its negative predictive values. So if it's lower than that negative range, the likelihood that there's amyloid is really very low. And I think we can kind of put that to rest. With a test like this, in a value that's not in the intermediate, but very solidly in the positive range, I agree with you. It might be enough for diagnosis, especially once there's FDA approval. But I think the bar is just a little higher when you're thinking about an amyloid targeting antibody because of the burden and the cost and the risks associated with the treatment. And so that's where I think, you want a biomarker that we have more experience with, that is more established than the plasma. And so I totally agree. If this person in our clinic was interested in amyloid targeting therapy, we probably would move ahead with a CSF or PET. If they were not, I think this would be enough for me as a clinician to counsel them that Alzheimer's is very likely contributing to their decline, and have a treatment plan short of the antibody that would be targeting the Alzheimer's pathway as well as the vascular pathway.
Excellent. Excellent. Thank you, Dr. Rabinovici. All right, let's do another case here. This is, again, a similar individual, only one lacunar infarction, but this person is on Eliquis, apixaban. They have atrial fibrillation. It's very well controlled, but they're on apixaban. We get an amyloid PET, and the amyloid PET was positive, clearly solidifying a diagnosis of Alzheimer's disease. In addition to having this completed, the neurologist ordered ApoE testing, and this person is an E4 homozygote. So if you had this clinical picture, what are your thoughts on amyloid targeting therapy, your approach to the patient? What sort of shared decision-making would you undergo with this individual? We've got a couple areas of caution here, right? We've got apixaban, which we kind of talked about. I see, thank you, Dr. Hetrick. She says she would probably avoid amyloid-targeting therapies. I completely agree. Nancy Kuhn said she would be worried about the risk of ARIA and the cardiovascular risk if the Eliquis is stopped. Another great point. Some people are so focused on I must get amyloid-targeting therapy that they consider stopping their Eliquis, and that is part of this shared decision making, absolutely. And there may be some individuals who are on maybe some Eliquis treatment because they had a remote DVT, and perhaps they could come off of Eliquis safely. But that's something where we would definitely want to involve the entire team in that decision-making process. What is your risk of a cardiovascular event if you stop? Or is it safe at this point that you can stop? It was just overlooked. Um, Dr. East made a great comment. Even if we're off of Pixaban, this person is an E4 homozygote. And there are some institutions in the United States who have just made an internal set of rules where they say we are not going to treat E4 homozygotes. Is that the right answer? In our institution, we treat E4 homozygotes. We educate them, we show them the same percentages you saw today, that there is a much higher risk of having ARIA. But if they really truly understand that, and we believe that there is a clear understanding, they have a good support system in place, a partner they live with who's monitoring them very carefully and closely, and they desire to undergo treatment, then we consider it. So really great points in the chat.
I
Another,
wanted to just
go
bring
ahead.
up, it's important, I think, to recognize that there are black box warnings for both these drugs, specifically for use in E4 homozygotes. So, again, doesn't mean they can't be treated, but enough for the FDA to give a box warning. The other point is that the ApoE4 homozygosity is one element, but you really should be looking at the whole patient, right? So, if they're E4 homozygous and they're on anticoagulation and they have microbleeds, boy, really high risk. There
Yep.
may be E4 homozygotes who are, have a clean MRI. They don't show any evidence of microbleeds or siderosis. Furthermore, what clinical stage are they, right? Are they really kind of in the MCI very early stage, or are they in that mild dementia stage, kind of pushing that MMSE cutoff that you have? Those are some additional things that you might use, right? The thinking more about benefits. So we do think that the benefit is greater the earlier you start these drugs in terms of clinical stage. Whereas, if a patient is more advanced, even if they technically meet the criteria, if they're higher risk and they're going to derive likely less benefit, that might push your shared decision making a different direction. Another element that we haven't really covered today is biological staging of disease. In the new AD criteria, the disease can be staged biologically using tau PET. This is something that's available in research. It's not really available in clinical practice, but at least in the donanemab trials, there was an even greater benefit in patients who were at earlier stages of tau spread. And this was also true in a subset of patients in the lecanemab trial that had tau PET. And so I think it's not quite ready for prime time, kind of like plasma biomarkers, but in the future, especially in these borderline cases, if tau PET is available and reimbursed clinically, it might help us with these borderline cases. If the patient is in really early stages of tau spread and likely to benefit more, it might be a different conversation about benefit versus risk than if they have a lot of tau in their brain and they're probably going to benefit less from amyloid lowering at that point.
Excellent. Yeah, thank you. Great points, Dr. Rabinovici. Before we move on to the next case, which will make the last one here most likely, I just wanted to address Dr. Caro's point. We have had some individuals who have atrial fibrillation who have gone on to get a Watchman device and then go on to therapy so that they could be off anticoagulation. Again, as Dr. Hetrick asked earlier, this is a moving target. We're gathering data on the safety of anticoagulation in this population, but to be as conservative as possible and to lower the risk as much as possible, being off would be best. And clearly, this is an opportunity for some individuals to be off of anticoagulation and lower their risk of amyloid targeting therapies. I'm going to skip this case and hit this last one because I think Dr. Rabinovici was making some great points on this. This is a 87-year-old Asian male with mild dementia due to Alzheimer's disease, we think, has amyloid PET positivity, um, has 3 microhemorrhages, some moderate white matter changes, but has a favorable ApoE E3 E3. They're very interested in starting amyloid targeting therapy. And so, this is a discussion that this person had with their neurologist, and what we brought up as an interesting discussion here. So, we have someone who is within the age range. In the studies, they went up to age 90 in clinical trials, right? So this person's age 87. Now, you also heard a dichotomy here that the younger a person is, and the earlier in their disease state they are, the more likely they are to benefit. So here's someone sort of at the high end of the age range, but they have a favorable ApoE profile, but they also have 3 microhemorrhages, and 4 microhemorrhages is kind of right near the cutoff. So we also know that as we get into our 90s, we see a lot more amyloid positivity, which may not necessarily correlate with disease. So there's a lot of gray zone that's here. And I wonder if if someone has any, clear thoughts on what they would do in a situation like this. I can tell you that, so Dr. East comments, and I like this one a lot. This is where knowing the specific findings on cognitive testing would help. I agree. Does this seem to be more of a mixed picture? Does it seem to be really pure Alzheimer's disease? Another great thing to think about is what is the functional level of this individual? We didn't talk about that very much in this case, but if, I've met 87-year-olds who are living independently, driving, shopping, doing all their financial matters, maybe even helping their kids who can't make it through life. But regardless, there is someone who is really super independent. And if you feel like that individual is a very young 87, that may be an excellent person to consider treatment on. Other comments or questions on this case that's kind of near a couple of gray zones in terms of treatment?
I think a really important factor that we haven't discussed is kind of the patient's values and preferences, and that really should factor into the decision making. If the patient meets the criteria and they're highly motivated, even if borderline, that may be different. But, some patients, the burden of the treatment, the frequent infusions, et cetera, given the benefit, they might say, well, maybe not for me. I'd rather spend this time doing other things than going to the infusion center every 2 weeks. So really getting a sense from the patient and their family about what their goals are, what their values are, I think is incredibly important and will tip us usually one way or the other in these borderline situations.
Awesome. Any other comments or questions? Great.
Oh, there's one in the
One
chat.
final question from Nancy. I may discuss amyloid targeting therapy, but emphasize the risks, expectations, and commitment. Shared decision making would be very clear about concerns. I agree. That's an excellent point that echoes what Dr. Rabinovici was saying. And then another comment. This describes a close family member who asked me to advise his neurologist recommended treatment. ApoE status is unknown. Yeah, and I agree, Dr. Hussein. I think you need more information. You need to really think about the potential impact of the disease and the treatment, and how a person might balance those two things. Great comments. Erica.
Yeah, no, thank you so much, Dr. Broch and Dr. Rabinovici, for great presentation. Thank you all so much for great discussion and your participation in the chat. I did just put a link in the chat again, where you can complete the post-test to claim your credit for participating today. And then also I had put it in the chat as well, but anyone that's interested in the slides, we can definitely send that. And if you need anything, I'll put the email in the chat. It's meetings@peerview.com. So you can feel free to reach out to us. But thank you so much, everyone, for your participation. And then as a reminder, the next session is January 9th. That's a Thursday at noon. So if you've registered for today, you'll get a reminder and everything for that. But thank you so much, everyone, for your participation, and I hope everyone has a great rest of the day.